Hi, very good morning. I'm Dr. Janak Patel. I'm MD General Physician. I'm not a cardiologist. Today I'm going to start with one of the very important topic, that is valvular heart disease, and among those we'll first talk regarding in general and then mitral stenosis. So whenever there is an involvement of the heart valvular structure, we call that as a valvular heart disease, which may be congenital or may be acquired. There are basically four valves. Two pulmonary and aortic valve, they are called semilunar valve, and tricuspid and bicuspid valve, tricuspid and mitral valve, they are called atrioventricular valve. Pulmonary, aortic or tricuspid. Tricuspid valve is also tricuspid, but mitral valve is having two cusps, anterior mitral valve leaflet and posterior mitral valve leaflet, and it is attached to what we call as a ventricle by chorda tendineae, which is attached to papillary muscle. That is how it is being attached. So any disease of this valvular structure, we call that as valvular heart disease. Basically, we come across two types of valvular involvement, which is what we call as a hemodynamically, it will produce problem in circulation, normal circulation. One we call stenosis and second we call regurgitation. Meaning of stenosis, the valve does not open completely, so that valvular ring area becomes less, and that produces resistance to blood flow from one chamber to another chamber. And regurgitation means valve does not close completely, so that the blood which will regurgitate back from one chamber to the chamber in which it is not supposed to flow. As for example, when the mitral valve closes, blood cannot flow from left ventricle into left atrium, but in a regurgitation, blood will flow from LV into LA. That we call as a regurgitation. Why? When the mitral valve opens, it does not open completely. It will produce resistance for left atrium to eject blood from LA into LV. This will call as a mitral stenosis. Now there are few terms which will be very frequently being utilized during valvular heart disease. One we call normal valve, stenotic valve, regurgitant valve. Second, depending upon the anatomical structures. And this particular is mainly utilized in pulmonary and aortic valve. We call valvular involvement, subvalvular involvement, or we call infundibular involvement, or we call as outlet obstruction. And if it is above the valve, we call supravalvular involvement. And that is mainly in case of what we call as stenosis rather than regurgitation, and mainly in pulmonary and aortic valve. We know anatomically there are four valves: mitral, aortic, pulmonary and tricuspid. So we call mitral stenosis mitral regurgitation, aortic stenosis aortic regurgitation, pulmonary stenosis pulmonary regurgitation, and tricuspid stenosis tricuspid regurgitation. As far as pulmonary and aortic stenosis, we use word valvular stenosis infundibular, or we call subvalvular, or we call supravalvular. These are the common terms which are being utilized. Etiologically, we classify them into congenital and acquired. And again, in congenital, mainly depending upon the number of cusps, we call bicuspid and tricuspid stenosis or regurgitation. As far as onset is concerned, it is acute or chronic. Severity wise, we classify into mild, moderate, and severe, depending upon the pressure gradient, depending upon the area, etc. And another time, we also use one term. It may be purely one valve involvement and one type of pathophysiology, we call isolated, or it can be associated along with other congenital heart disease. Say, as for example, pulmonary stenosis may be there in presence of Fallot's tetralogy or Fallot's pentalogy. Mitral stenosis may be present along with ASD, we call Luttenbecker. Or you might have a two valvular structure or three valvular structures involved together. So these are the different terminology which are very frequently utilized while we'll be discussing on a valvular heart disease. We divide the etiology into two big groups, acquired and congenital. Already we have mentioned that congenital can be bicuspid, congenital heart disease, or associated with other defects. And the common congenital defects, which can be bicuspid and may be having stenosis, that is pulmonary stenosis, aortic stenosis. These two are bicuspid valve, congenitally defective, or you can have a tricuspid stenosis, mitral stenosis. You can have a infundibular aortic valve subvalvular stenosis, we call idiopathic hypertrophic subaortic stenosis, or also described as HOCM, hypertrophic obstructive cardiomyopathy. You can have a floppy valve, that's why it is called mitral valve prolapse, or it is called floppy mitral valve. You can have a aortic regurgitation, and if there is an mitral stenosis with ASD, it is called Luttenbecker. You can have tetralogy of Fallot associated with pulmonary stenosis. Epstein anomaly is with tricuspid valve malformations, and Marfan syndrome is very frequently with aortic regurgitation, aortic root dilatation, aortic aneurysms, etc. These are all congenital valvular defects or associated with valvular defects. While among acquired, the most common is rheumatic valvular heart disease. During acute, you can have MR, mitral regurgitation. Very rarely we come across other valve involvement during acute rheumatic fever. But by and large, the valvular disease which are secondary to rheumatic heart disease, they are usually chronic. They are very rarely acute, and we already told you in acute you come across only mitral regurgitation as a common mode of presentation. But chronic rheumatic heart disease or chronic rheumatic valvular heart disease will be mitral valve is the most common involved, which can have a mitral stenosis alone or mitral stenosis with MR or mitral regurgitation alone, any permutation combination. And this mitral valve may be involved along with aortic valve like aortic stenosis, aortic regurgitation, and absolutely rare, that is with pulmonary stenosis. By and large, aortic regurgitation with mitral stenosis or rheumatic arthritis, RA, rheumatoid arthritis, involving aortic regurgitation, aortic valve producing aortic regurgitation, is not commonly associated with mitral stenosis. So it is mainly AR, not with mitral stenosis. Second common etiology is atherosclerosis, which produces stiffness of the aortic valve, mainly by calcification and that we call as a calcified aortic valve producing aortic stenosis. In ischemic heart disease, because of acute myocardial infarction or because of what we call as papillary muscle rupture, chorda tendini rupture, or papillary muscle dysfunction, it will produce MR. And this is acute mitral regurgitation, which will end up into acute left ventricular failure. Infective endocarditis will destroy mitral valve, aortic valve. Rarely there is an involvement of a pulmonary or tricuspid valve. So they will result into regurgitation because of destruction of the valvular structure, and it will end up with an acute etiology. So in MR and AR you will have a left ventricular failure, and in TR and PR you will have a right ventricular failure. Syphilis nowadays not commonly seen, but syphilis will produce aortic valve involvement, producing aortic regurgitation and aortic root involvement, producing aortic aneurysm, and that aneurysm can be also in an arch of aorta. Cardiomyopathy, by and large, it is a congenital cardiomyopathy, and in which a dilated cardiomyopathy will produce dilatation of the ventricular chamber, producing dilatation of the ring, and that will produce MR, very, very common. While hypertrophic variety will produce subaortic stenosis like IHSS or HOCM, we call it the idiopathic hypertrophic subaortic stenosis, or HOCM we call it the hypertrophic obstructive cardiomyopathy. These are usually congenital. Dilated cardiomyopathy can occur in an ischemic heart disease, diabetes, alcohol, etc. You can have a traumatic damage during surgical procedures or while doing catheterization, right heart, left heart catheterization. Particularly while doing a left heart catheterization, you can get damage to mitral and aortic valve. You can have damage to tricuspid valve and pulmonary valve during right heart catheterization. And during a valve replacement also, you can have post-surgical MR and AR. Very, very common. Quite common. In collagen disorders, MR and AR are common. Carcinoid tumors can produce involvement of tricuspid valve and occasionally mitral valve. Mainly right side is more commonly involved as compared to left side. So that will produce more of tricuspid stenosis rather than mitral stenosis. SLE can involve the valve, the undersurface of the valve, which is called Liebman-Sack type of a valvular involvement, and it can end up in mainly most common valve being involved is mitral valve, which can produce MR or MS. I forgotten to mention in a congenital heart disease, that is along with Marfan syndrome, there are a lot of other conditions which can also have involvement of the valvular structures like Ehlers-Danlos, collagen disorders. Also, you can come across in case of Down syndrome, Noonan syndromes, etc. In those conditions also, once in a while, you can have a valvular structure involvement. If we divide into acute and chronic, during acute rheumatic fever, most common is MR. Acute myocardial infarction, the most common is again MR because of necrosis or rupture of papillary muscle. Infective endocarditis also can produce MR, AR most common, and occasionally TR and PR. We already mentioned in a traumatic pathophysiology or post-surgical MR, AR is more common than TR and PR. In dissecting aneurysm, again AR is common. All these are acute and they are mainly regurgitation. You can see those are all regurgitation. It is because of destruction of the valve. And this will produce acute overload on the chamber in which they are opening. And that will be either left ventricular failure or a right ventricular failure. In TR and PR, right ventricular failure, while in MR and AR, left ventricular failure. While in a chronic variety, the commonest variety we already described, chronic rheumatic valvular heart disease, syphilis, SLE, rheumatoid arthritis, atherosclerosis, cardiomyopathy, congenital variety, carcinoid tumors, etc. They can be, depending upon the severity, mild, moderate and severe. They'll produce changes in the chamber. So we basically divide into regurgitation and stenosis. Stenosis are always chronic, but regurgitation can be acute or chronic. You can see that very well. Aortic valve can have regurgitation or stenosis. Regurgitation can be acute or chronic. And we have already told you, acute variety, the most common variety, which is infective endocarditis. We have already shown you here. Infective endocarditis, traumatic damage. While in mitral regurgitation, it can be also acute myocardial infarction or even in case of an ischemic episodes. While stenosis is usually because of the chronic pathophysiology. So you can have a chronic pathophysiology producing stenosis. So that is usually the permutation combination. Now this is some of the picture. This is typical rheumatic involvement. This is SLE, which is involving the undersurface of the most common valve involved is mitral valve. This is non-bacterial thromboembolic. So it is a non-bacterial involvement, also called as Marantec involvement. And this is infective endocarditis, which involves the valvular surface of a valve, and then it will produce destruction, local destruction. And following a destruction, you will have mainly regurgitation rather than stenosis. These are all the other valvular structures which are being shown. Say this is a tricuspid aortic valve with calcification. You can see lot of calcification. This is a tricuspid valve, 3-cup valve, and this is 2-cup valve. This is 2 cusp only. So this is bicuspid, this is tricuspid, but this is aortic valve, which is having a tricuspid aortic valve. This is a bicuspid aortic valve, showing you a calcification. And this is rheumatic etiology involving mitral valve producing stenosis, and it is good number of times described as a fish mouth appearance. And this is a normal valvular structure, will be shown here. You can see this is a normal valvular structure, absolutely thin, papery and nearly transparent, and see this valve involvement. These are the valvular structure which are normal, and this is a calcified tricuspid aortic valve. This is bicuspid calcified aortic valve. This is rheumatic mitral valve involvement, thickened, and you have got a rheumatic material deposited. You can see this inflammatory material deposited. So aortic calcification. To find out the pathological effect, you have to know from where the blood is flowing. Already we have discussed, and we will be discussing separately, individually in each valvular heart disease, that we always call semilunar valve will open during ventricular systole and close during ventricular diastole, while AV valve, that is mitral and tricuspid valve, will open during ventricular diastole and will close before ventricular systole starts, at the end of ventricular systole. At the end of ventricular systole, the mitral valve and tricuspid valve will open after end of ventricular systole, while at the beginning of ventricular systole, the aortic valve and pulmonary valve will open at the end of ventricular systole. And at the beginning, you will have a closure of mitral valve and tricuspid valve, and aortic and pulmonary valve will open as soon as the systole begins. And there is a short period we call as a isometric contraction period. So we don't go into that cardiac cycle detail at present. And closure of mitral and tricuspid valve will produce first heart sound, we call M1T1. And closure of aortic valve and pulmonary valve produces a second heart sound, we call A2P2. A2P2. And just after A2P2, that is after the second heart sound, that is after the closure of that particular aortic valve and pulmonary valve. Now the ventricular diastole will begin. You will have opening of the mitral valve and tricuspid valve after second heart sound. And before a mitral valve and tricuspid valve closes, which produces the first heart sound, little after that first heart sound, you will have an opening of aortic and pulmonary valve, which will be the beginning of ventricular systole. This is a pathophysiology which will be showing you again in a patient's all mitral stenosis, aortic stenosis, etc. So this is that typical picture of stenosis. This is of regurgitation, which will be using again in a stenosis and regurgitations. This is one of the slide which we have shown you that now there is a procedure we call as a catheter. By use of a catheter, that's why it is called transcatheter, and you are replacing a valve. So aortic valve is replaced, and we call implantation. So it is a transcatheter aortic valve implantation, and you remove the catheter, the valvular structure will stay there. So that's why it is called TAVI, transcatheter aortic valve implantation. And when you replace the aortic valve, then it is called transcatheter aortic valve replacement, AVR, TAVR, aortic valve replacement. So we end this particular portion of general valvular disorders and terminology, etc., which we have explained you. All those terms will be now utilized in further lectures. So we are now extending into the second part we call as the mitral stenosis. So we'll be talking now about mitral stenosis. So definition of mitral stenosis is when mitral valve opens during ventricular diastole. The opening area of a normal mitral valve opening is 4 to 6 square centimeter. Instead of that, if it opens an opening area is less than 1/3 the original size, or we call less than 2 square centimeter, then we call that as mitral stenosis. Again I am repeating, normal opening area, this opening area, complete opening area, this is a right side, this is a left side. So this opening area of mitral valve, normal person is 4 to 6 square centimeter. If it is less than 1/3, so less than 1/3 is 2 square centimeter, then we'll call that as mitral stenosis. Certain words are utilized. The most common pathophysiology, it is because of the chronic process. So it is usually we call as a chronic mitral stenosis. Severity wise mild, moderate and severe. Etiology wise congenital and acquired. It can be purely isolated or may be associated with congenital heart disease like ASD, we call Luttenbecker. There are some conditions which mimics identical like mitral stenosis. So pathophysiology just is like mitral stenosis, but there is no involvement of mitral valve. That is left atrial myxoma. Left atrial myxoma. There is a second condition called as a cord triatrium, and there is one more condition is a left atrial thrombus, ball valve thrombus of left atrium. We'll be discussing in a pathophysiology shortly. As far as a mild, moderate and severe is concerned, they utilize mean gradient or pulmonary artery systolic pressure or valvular structure. So mild is mean gradient less than 5, systolic pressure less than 30, and valvular area more than 1.5. Less than 2 is stenosis, but if it is between 1.5 to 2, we call it a mild. If it is between 1 to 1.5, moderate, and severe is less than 1. And as far as the pressure gradient is concerned, mean gradient less than 5 is mild, 5 to 10 is moderate, more than 10 is severe. And pulmonary pressure, if it is more than 50, it is straightforward severe variety. So between 30 to 50, it is moderate. So these are the three factors which can be considered to put them into mild, moderate and severe. Very commonly these are being utilized. So depending upon the area and gradient, and some person also utilize the symptoms. If the valvular area is between 1.5 to we call 2, it is mild. Between 1 to 1.5, moderate, and severe is less than 1 square centimeter and person is symptomatic. And gradient wise, we have already told you, more than 10 millimeter is severe, between 5 to 10 is moderate, and less than 5 is mild variety. Etiology. Almost we say that unless proven otherwise, mitral stenosis is because of chronic rheumatic valvular involvement. So it is almost accounting for 77 to 99%. I'll say almost 99% unless proven otherwise. You can have a calcification of a mitral valve, very rare, not common. It accounts for 2 to 7% and mainly common in a old age person. More commonly, aortic valve is more commonly involved as compared to mitral valve. Infective endocarditis producing mitral stenosis, absolutely again rare. They say in 3.3%, but I'll put it rare. These two are not common. Congenital, again they are rare. It can be in a Fabry disease or Whipple's disease. Another common group is SLE, rheumatoid arthritis, carcinoid syndrome, prosthetic valve, which can get involved. This again are rare. Indirectly we say the rheumatic unless proven otherwise. Second common, which can be because of SLE, rheumatoid arthritis, carcinoid syndrome, etc. And congenital groups. Female are more prone as compared to male. Ratio is almost 6:1. Almost 60% of patients do not have a history of rheumatic carditis, acute rheumatic carditis. And 50% of the patient who has got acute rheumatic carditis do not develop valvular heart disease. Do remember this. But the commonest cause of mitral stenosis, 99% of the time, is rheumatic. In Luttenbecker, ASD is associated with mitral stenosis. Some people say that it is MS is rheumatic heart disease, may be associated with ASD. Exact mechanism is still not known, but it is labeled as Luttenbecker. Good number of times they describe that ASD and MS both are congenital. Certain drugs like methotrexate can also produce involvement of the mitral valvular structure producing mitral stenosis, and we have already mentioned left atrial myxoma, quadri atrium and ball valve thrombus in left atrium can produce identical like mitral stenosis, but mitral valve is absolutely normal. So common condition we already mentioned, rheumatic and congenital comes topmost on the list. Then carcinoid syndrome, cardiac fibroelastosis, prosthetic valve can get stuck and can produce stenotic valve, and mucopolysaccharide disorders. This also can produce mitral stenosis, but the most common is rheumatic congenital. You can put carcinoid syndrome, and another is prosthetic valve occlusion. As far as pathophysiology is concerned, I am not going into etiology which is involving the mitral valve, but what will happen if the mitral valve is involved, that will go through, because you can have involvement of the mitral valve, commissure can be involved, cusp can be involved, chorda can be involved, or it can be combination of permutation combination of any one of this. And being a rheumatic valvular, it is mainly because of fibrotic process which produces and calcification secondary. We divide into two big groups we call acute and chronic. By and large, in stenosis there is no acute pathophysiology. All are by and large chronic. Absolutely rare to get an acute occlusion of a mitral valve. That can happen in a ball valve thrombus, but not common, rare. So we take it for granted it is a chronic. Now depending upon the severity, that is a diameter. If diameter is between 1.5 to 2, we call it a mild. If it is between 1 to 1.5, it is called moderate. And less than 1, we call it a severe, or we call critical. So if we get critical, it will produce more severe symptoms and rapid changes in pressure gradients, etc. So I'll explain very simple way. In a normal person, blood from LA is easily entering into LV because the mitral valve opens completely. This area of opening is normal. It is between 4 to 6 centimeter. So it is normal. So there is no resistance to LA. So it does not produce any hemodynamic changes. But say if a person has got severe stenosis, because of severe stenosis, the opening of the valvular opening is very small. So it produces resistance to the blood flow from LA into LV. LA has to do more work. So there is increased pressure in LA. LA will undergo compensatory hypertrophy. Being a chronic, it undergoes hypertrophy. It tries to compensate. In that, it also undergoes volume enlargement because there is a less blood is going from LA to LV. So it will undergo dilatation plus hypertrophy. So first chamber to be affected is a LA. Now what happens because of that? We'll be taking into two. We'll be taking changes because of LA and changes because the quantity of a blood which is coming to LV. So if I take together and if I show you the second chapter, that is what will happen in LA. Because the left atrium has to do more work, left atrium is undergoing hypertrophy and it is undergoing enlargement. So it is a dilatation plus hypertrophy. Because of overstretching of the left atrium, because of dilatation, the person will invariably get arrhythmia like atrial flutter fibrillation. And secondary to atrial flutter fibrillation, there is a decreased blood flow in left atrial appendage that will give rise to formation of thrombus, and from that thrombus you can get the thromboembolic phenomena which will go into systemic circulation and produce systemic embolization. Left atrial pressure is elevated because there is an increased workload we call as afterload on LA, that is producing increased LA pressure, that will have increased pressure in the pulmonary vein. So pulmonary venous pressure will be elevated. Depending upon how fast the pulmonary pressure gets elevated, you will have a pulmonary hypertension development. In case of mild and moderate, it will take a long time to develop a pulmonary hypertension. As there is a pulmonary hypertension, now right ventricle has to work against the resistance because right ventricle has to eject the blood into pulmonary circulation, and in a pulmonary circulation there is a pulmonary hypertension. So this will produce right ventricular pressure overload, which will undergo overwork, right ventricular hypertrophy, right ventricular pressure elevation, right atrial pressure elevation, right atrial enlargement, and you will have a right ventricle will not be able to compensate, and you will start getting what we call as a right ventricular failure. And secondary to right ventricular failure, now you will have a increased pressure in a superior vena cava, increased pressure in a inferior vena cava, and because of dilatation of right ventricle, you might even get tricuspid regurgitation, and you will have a jugular venous distension. JVP will be elevated, JVP will be full pulsatile. Now this is happening because the blood cannot flow forward because of stenosis. So this is called backward. This is all changes which are taking backward. So this is the pathophysiology of stenosis. The blood which is entering from RV into lung is getting fully oxygenated. So fully oxygenated blood is coming to LA and that is entering into LV. But because of stenosis, less blood is coming to LV. So LV filling is less during diastole. Because filling is less, left ventricular and diastolic volume will be less. Left ventricle is not affected. The quantity of a blood coming to LV is less. So you will have a less blood coming to LV and diastolic volume is less. Ejection is good, but volume was less, so cardiac output also decreases. Because cardiac output decreases, the blood pressure also falls. So in a person with mitral stenosis, you will have a decreased cardiac output producing a low volume pulse and fall of blood pressure. So blood pressure, systolic pressure will be less and even a diastolic pressure will be also reduced. But the blood which is ejected out is fully oxygenated, hence there is no hypoxia or there is no cyanosis. But the quantity of a blood which is ejected out is relatively less. This will be typically in case of a mitral stenosis. Now this damaged valve can get involved by infective endocarditis, and secondary to infective endocarditis you can have dislodgement of this infected material and producing systemic embolization, which will be infected material, and you will have all symptom signs of systemic embolization which happens in an infective endocarditis like osseous node, Janeway's nodes, splinter hemorrhages, splenic infarct, splenic abscess, meningitis, brain abscess, etc., which we have already discussed before in infective endocarditis. But if there is a dislodgement from this LA thrombus, it is non-infective material, it will produce plain simple thromboembolic phenomena into systemic circulation, and there will be no infective pathophysiology in that embolism. This is the entire slide. Whatever I have discussed is shown here. That is pathogenesis and clinical finding. At your leisure time, you can easily go through. These are all the findings what you come across. These are what we call as sounds wise. I'll try to explain that. This is right side failure, cardiogenic shock, and heart failure. What can happen? So I'll show you this one slide just before. But this is a very nice slide which shows you everything in one slide only. So at your leisure time you can go through very easily. It is showing you entire pathophysiology plus clinical finding what are going to happen. Now because the valve is very tight, now I'll show you here. Because this valve is very tight, when it tries to open, because mitral valve is opening during ventricular diastole, little after second heart sound. So at that time, as the valve is very stiff, it can produce a sound which we call as the opening sound. It is good number of times described as the opening snap. So you will get a sharp sound little after second heart sound, and that will be best heard in the mitral area called as a opening snap. And because there is a narrowing, now blood flow will produce a turbulence across that stenotic valve, and that is during a ventricular diastole. So it will produce a sound we call as a murmur. and that we call as a mid-diastolic murmur. And at the end of ventricular diastole, there is a powerful atrial contraction that will produce pre-systolic, or we call as the end diastolic crescendo murmur. So it is a mid-diastolic murmur with an end diastolic crescendo murmur, which will be typically in case of a mitral stenosis. So that will be there. Now, because of pulmonary hypertension, P2, that is pulmonary valve closure, will be sharp, and that will produce P2 loud. So you will have a first heart sound will be loud. You will have an opening snap, followed by a mid-diastolic murmur, followed by an end diastolic murmur, which will be a crescendo murmur. You will have a P2 loud, and you will have an opening snap. This will be very, very typical. Secondary due to infective endocarditis, if there is a destruction of a mitral valve, you can have a mitral regurgitant murmur, which can be fresh murmur or a new murmur. These are all the things what can happen. And because of pulmonary hypertension and because of failure, you will have a dyspnea. In a case of a severe stenosis, that is where the diameter is less than 1 square centimeter, you will have a more of or severe left atrial pressure elevation, and secondary to left atrial pressure elevation, you will develop pulmonary venous pressure elevation, and you can have pulmonary edema, which will produce orthopnea, paroxysmal nocturnal dyspnea, and even blood-stained frothy sputum. By and large, because of a right ventricular failure, which is a gradual in a mild variety, usually in a chronic, if it is a mild, there is a gradual changes which produces pulmonary hypertension, right ventricular hypertrophy, and then followed by a right ventricular failure, where you will have a edema, puffiness of face, JVP elevated, hepatojugular reflux, hepatosplenomegaly, congestive hepatosplenomegaly, etc. This will be the two different types of picture you will come across in your everyday practice. So this is a normal mitral valve, which will increase the left atrial pressure, increase in pulmonary pressure, pulmonary congestion, decrease in oxygenation, which will produce fatigue, dyspnea, orthopnea, and right ventricular pressure elevation, and you can get right side failure. Because of increased left atrial pressure, left atrium has to do more work against resistance, hypertrophy as well as dilatation. Decreased blood flow to left ventricle, decrease in the cardiac output, left ventricular chamber will not be enlarged. You usually don't get atrophy, but you don't get enlargement. And there's a decreased cardiac output, so decreased blood supply. So a person can complain of fatigue. Further in detail, if you say decreased mitral valvular area, left atrial pressure elevation, in compensation left atrial enlargement, and secondary to left atrial enlargement, this can now produce a pressure effect on the surrounding structures. And secondary to pressure effect on the surrounding structure, it can produce damage to the left bronchus, left recurrent laryngeal nerve, and also pressure effect on the esophagus, producing dysphagia, hoarseness of voice, also called as Ortner syndrome, and pressure effect on the left bronchus, producing hemoptysis, cough, and can even produce atelectasis, and which can end up with a sudden dyspnea. Because of atrial fibrillation, we have told you that there is a left appendage thrombus formation, and from that you can get a thromboembolism. Usually in a mild variety and gradual pressure changes, you will develop a pulmonary hypertension, right ventricular pressure overload, right ventricular hypertrophy, followed by right ventricular pressure elevation, decreased cardiac output, and then person goes into right ventricular failure. and in that person will develop now fatigue, dyspnea, etc., lower limb edema, puffiness of face, those particular. We have already told you that because of left atrial enlargement, atrial flutter fibrillation, thromboembolism, stroke, this will be non-infective, but because of infective endocarditis, if there is a dislodgement, it will produce infective. Decreased ventricular filling, high pressure rupture of pulmonary vessel producing hemoptysis, and because of atrial fibrillation you can have palpitations. And if it is acute severe fibrillation, you can have increase in left atrial pressure which can precipitate pulmonary edema, and because of increased pressure in acute elevation of left atrial pressure, more commonly it is in a severe mitral stenosis, you can develop an pulmonary edema which can have orthopnea, blood stained frothy sputum, and person can even develop cyanosis. And because of pressure effect on the recurrent laryngeal nerve, you get hoarseness of voice called as Ortner syndrome, and good number of time it can also produce a pressure effect because of a big left atrial dilatation, which is more common with MR rather than MS, and that can produce pressure effect on esophagus producing dysphagia, and pressure effect on a left bronchus producing hemoptysis and collapse. And this is all because of right ventricular failure, hepatomegaly, splenomegaly, peripheral edema, JVP elevated, tricuspid regurgitation, etc. Indirectly, this is the entire picture of mitral stenosis. Same thing shown, what is shown here because of atrial flutter fibrillation. At your leisure time, you can go through. This we already shown you before. Area between 1.5 to 2, mild between 1 to 1.5, moderate, and severe less than 1 square centimeter, and gradient less than 5 in mild. If the gradient increases 5 to 10, moderate, and more than 10 is called severe. So this is the way it is classified. This is if there is a thrombus formation, it blocks acutely the mitral valve opening, then it is called left atrial thrombus where mitral valve is not involved. Myxoma is pedunculated in certain position, it can block the mitral valve opening, producing identical like mitral stenosis. So this is a left atrial thrombus which is free and can block, and as it is a shape like a ball, it is called as a ball valve thrombus. This is a myxoma which can produce occlusion, and it is pedunculated tumor of a left atrial, so it is a left atrial myxoma. And if you have got a septum with a small opening, this will produce two chamber in a left atrium. That's why it is a three chamber. Right atrium and left atrium is having a two chamber, that's why it is called quadriatrium. Tri means three. This is 1, this is 2, and this is 3. And this works identical like a mitral valve. But mitral valve here is normal. So that is quadriatrium. This is LV. And that is LA. Mitral valve is normal in all these three conditions. Symptom we already discussed. The commonest symptom is dyspnea, which is because of pulmonary hypertension, pulmonary venous congestion. Fatigue is because of diminished cardiac output, and that produces decreased tolerance to increased volume, inability to tolerate increased heart rate. As soon as the heart rate is increased, person develops decompensation. We have already told you that because of the increase in pressure, you even get a rupture of vessels in pulmonary vasculature producing hemoptysis. Also you can get hemoptysis secondary due to acute pulmonary edema, but it will produce blood stained frothy sputum. Sometimes you get a malar rash, which is typically described as a mitral face. You will have a increase redness, over the face and nasal nose, and that is typically described as a mitral phase. So you will have a fatigue, palpitation is very frequently because of atrial flutter fibrillation. Cough is very frequently because of increased pulmonary venous pressure, shortness of breath. If a person has got a severe mitral stenosis, he will develop a left side failure. Actually, not a left ventricular failure. We use a left side failure, or we call pulmonary edema, which produces orthopnea and paroxysmal nocturnal dyspnea. Infective endocarditis, systemic embolization, pulmonary infections, hemoptysis. In a mild variety, usually they develop right side failure, producing hepatomegaly, splenomegaly, ascites, edema, puffiness of face, JVP elevated, distended and elevated, hepatojugular reflux present. And in case of infective endocarditis, person will have a fever, anemia, tachycardia, etc. And I've already mentioned because of atrial flutter fibrillation, palpitation and systemic embolization. Quite common. These are all the phases. Typical mitral phase. It is described as typical mitral phase. It is because of cutaneous vasodilatation in severe mitral stenosis. And I've already explained you on auscultation. First heart sound will be loud. Opening snap will be just after second heart sound. There will be a mid-diastolic murmur, base third in the mitral area, with pre-systolic, what we call the end diastolic crescendo murmur. In respiratory system examination, you will have a crepitations because of pulmonary edema. Because of right ventricular hypertrophy, you will have a right ventricular parasternal heave. P2 will be loud. And because of tight mitral valve, you can have an opening snap, and that will be heard immediately after second heart sound. Fever will be common in infective endocarditis. We have told you. Syncope is quite common if a person has got wall thrombus. Chest pain may be because of coronary microembolization, or there is an increased load on the right ventricle, etc. We already described that the murmur will be based in mitral area. It will be MDM with pre-systolic accentuation or pre-systolic crescendo murmur, pre-systolic, rumbling in character, grade 3 to 6, not 6, but it is usually grade 3 or 4. This is a typical mid-diastolic murmur with a pre-systolic, or not pre-systolic, end diastolic accentuation. Secondary to right ventricular dilatation, you can have a Graham-Still murmur, which is we call as a murmur because of PIA, and you can have even a diastolic murmur. That will be because of tricuspid incompetence. You can have that. These are the typical features which we have already described: dyspnea, orthopnea, PND because of a pulmonary edema, hemoptysis, atrial flutter fibrillation, producing palpitation, systemic thromboembolization, Ortner syndromes, and pinkish purplish face. We have already described. First heart sound will be loud. You will have an opening snap, mid diastolic murmur with end diastolic crescendo murmur, and these are the findings in investigations. We'll be coming into investigations. At your leisure time, if you are interested, what will be the typical investigative finding on what we call as an echo, as well as on a right heart catheterization or left heart catheterization, what pressure gradients, what will be the diameter, etc. You will come across. These are the two slides which I have put here. You can go through if you are interested. Common investigation we go for is chest X-ray, ECG and echo. If you are planning for surgery and you want to separate them into mild, moderate and severe, you can go for cardiac catheterization combined with MRI or CT. That is the common. So on an ECG, very frequently you will come across in an ECG, you will see P mitral, we call it is that P wave is broad and notch. Good number of time because of a big left atrial enlargement, you can have atrial flutter fibrillation where you will not be able to see P mitral. In a chronic and mild variety, usually you come across right ventricular hypertrophy. In case of severe type mitral stenosis, you will see mainly P mitral. You may not be having a good amount of RVH because right ventricle doesn't get chance to compensate. Before that, person develops pulmonary hypertension. In a chest X-ray, mainly you get an enlarged ALA and signs of pulmonary venous congestion. If you want to demonstrate an enlarged LA, you can have a barium meal in a lateral view. We have got one X-ray, will show you that. In an echo and cardiac catheterization, you can demonstrate lot of things. In an echo, you can demonstrate the severity of involvement of the mitral valve opening area, which type of mitral valve involvement, whether calcified or it is fibrosed. Is there any other associated valve involvement or is there any associated congenital heart disease? Severity of LA enlargement, presence of left atrial thrombus, involvement of the mitral valve by infective endocarditis. Is there any quadraatrium or left atrial myxoma or a ball valve thrombus? The LV and diastolic volume, right ventricle hypertrophy, severity of right ventricular pressure, pulmonary pressure, all those you can demonstrate on echo. And if you combine with Doppler, you can demonstrate even a pressure gradient across the mitral valve. Cardiac catheterization mainly is utilized to find out the severity of coronary artery involvement and pulmonary arterial pressure and severity of other valvular structure involvement also prior to surgery. ECG we have already mentioned, big left atrial enlargement, that is broad and notch P wave, which will be very classical seen in lead 2. You can have atrial flutter fibrillation and RVH will be very commonly seen. X-ray, we already told you, mild cardiomegaly because there is mainly RV and big LA. In a severe variety, you can see symptom signs of pulmonary congestion along with curly A line, curly B line. And echo will demonstrate all those what we have mentioned before. So I'll now directly go to, you can see here, these are called 4 signs. 4, 1, 2, 3, and 4. Right pulmonary artery, this is aortic knuckle. Then you have got a left pulmonary artery, left atrium, and this is left ventricle. Clear? This is breast shadow. This is a breast shadow. And this side, you got a 2 arrow showing you one which is inside the other haziness. So this is LA and this is RA. So this is called double atrial shadow. LA and RA. So it is a double atrial shadow. And this is the bronchus. And see, there is a mark. This carina. This is called carina angle. And that is broadened out because of big LA. So these are some of the findings which you can easily identify. So on the left side, you will see aortic shadow, followed by pulmonary artery shadow, followed by left atrial, and then by LV. While on the right side, if there is a 4, it is also called as a 4 bump sign. 1, 2, 3, and 4. 4 bump signs. And you can get increase in carina angle, and on the atrial side, you can have a double atrial shadow. Sometimes these are enlarged so much that you cannot separate out those bumps. Then we call it a mitralization. Then usually we use the word mitralization. You can see there is one more shadow on this right side. So this is left atrium and this is right atrial border. So it is LA, this is mitralization, this is double atrial shadow. So if there is a very good enlargement of a LA, then you can have a double atrial shadow. And when there is a almost, you cannot make out the 4 bumps on left side, which is because of aorta, pulmonary artery, left atrium and LV border, then you call that as mitralization. This you can see in a lateral view. You can see a pressure effect on an esophagus. This is because of a big LA. You can see there is a big LA. This is pressure effect. And that can happen if there is a tight mitral valve. This is after mitral valve, 3 valves are replaced. This is mitral valve. This is aortic valve and this is tricuspid valve. So these are 3 valves replaced in one single person. ECG I have already mentioned. Mainly it will show you P mitral, that is M shape, broad and notch. But by and large, because of a atrial enlargement, left atrial enlargement, you will get atrial flutter fibrillation and you will have a big RVH. So typical RVH you will see R wave prominent in V1 and in AVR, and if P wave is seen, then it will be broad and notch, typical M shape. You can see here broad and notch, but base seen in lead 2. See here also it is seen very clear. So this type of notch P wave will be seen. It is called P mitral. So you will have a P mitral, and in what we call as V1, you will have a R wave appearing and which will be taller, and you will have a little S wave in V1, V5, V6, sorry, V5, V6. You will have a deep S wave in V5, V6. You will have a S wave in a RVH. So in a V1, you will have a tall R wave and deep S wave in V5, V6. Differential diagnosis I have already mentioned. As far as management is concerned, medical treatment for failure, antibiotics in presence of infective endocarditis, mainly in medical treatment, diuretics and digitalis. If there is an atrial flutter fibrillation, antiarrhythmic drugs. To prevent thromboembolism, anticoagulants. And in a person who has not developed infective endocarditis, you can use prophylactic treatment to prevent infective endocarditis. And after medical management, control of all the things, that is control of infective endocarditis, control of failure, prevention of thromboembolism. Now you can decide regarding a surgical treatment. There is one which was done previously, was open valvotomy. Now days of open valvotomy is gone. If there is a very tight calcified mitral valve, usually they go for mitral valve replacement. But nowadays there is a simple procedure which is being done, is called closed mitral valvotomy, or it is also called closed mitral commissurotomy, but by and large the word utilized is mitral valvotomy, where you use a catheter, you use a balloon, you inflate the balloon and you do a valvuloplasty. So that is a procedure which is being done. It is called balloon mitral valvuloplasty, or it is also called as a percutaneous balloon mitral valvoplasty. So PBMV or BMV, depending upon what procedures you are doing. So these are the flow charts which are being mentioned. At your leisure time you can go through. So in which case you can have a little observation, and in which case you require a percutaneous mitral balloon valvoplasty, etc. So these are 3 slides which are there. depending upon your clinical finding, area, pressure gradients, etc. What you can decide. These are the flow charts, or we call algorithms. So mainly treatment is medical, diuretic, digoxin, beta blockers, anticoagulation, and infective endocarditis prophylaxis. These are the different types of valve which are being utilized. This is a balloon valvotomy or valvoplasty. Also they used to call commissurotomy. So some people use the word commissurotomy or valvuloplasty. And when you replace the valve, it is called MVR, mitral valve replacement. This was mechanical valve. Now they are being replaced by biological or bioprosthetic valves. These are now bioprosthetic valve which are being utilized. And this is percutaneous balloon mitral valvuloplasty. You can see here the catheter is introduced from here via the atrial septum into the left atrium, and then with the balloon you inflate the balloon and dilate it, and procedure is over. So very simple. And if the valve is very much calcified, then you replace it by artificial valve. Complications, atrial flutter fibrillations are very common. Thromboembolism, acute pulmonary edema only in case of a severely tight mitral valve stenosis. By and large, it will produce right ventricular failure, more common in a mild variety and moderate variety. Thromboembolism, infective endocarditis and thromboembolism, endocarditis, and in case of endocarditis, you can have an infective embolization. So I end my lecture here. I hope this will be very helpful to you. And this is one of the most common valvular heart disease you will come across in your everyday practice. And the commonest etiology of this mitral valvular heart disease is rheumatic fever. And that is we call as a chronic rheumatic fever.